Good evening, and Happy New Year to you, Dr. Moss, and Happy New Year to all of you who have decided to take time out of your schedule to join us for another installment of Mental Health Mondays. We're excited about this new topic that we will begin of the new year, a topic that will take us through the next month, the real on racism. And tonight, specifically, we will talk about the health gap. One of the things, and we might say to you, welcome, Dr. Moss.
It's glad to be here, man. Happy New Year to you.
And as I was sharing with you earlier, I'll share with you again, there's just something about seeing you in that white coat. I think I ought to take my blood pressure. But I thank you for your sacrifice and your participation in our efforts to inform our viewing audience of the importance of being up on mental health, and especially in general, being up on their health as well. So as we dive into this subject, the health gap, I'm going to ask you a question that I didn't plan on to ask you till now. Tell me why you became a physician.
You know, I felt that God had called me to help people. And I felt that God wanted me to help people with their mind, body, and their spirit. And that's been the mission from day one. So the plan was for me to play football and then have a backup career as a doctor.
Okay.
The football part never happened. So here we are. God blessed me in a great way.
Right. Amen. Well, I think it's awesome. And from the feedback that I hear via my producer, that many of those who attend your clinics see the genuineness in you and the sincerity and the great care that you and your staff give them at Mighty Psychiatry.
Thank you.
So as a physician, as you think about health disparities between African Americans and their white counterparts, we know that an oath that every physician takes is the statement that is made, do no harm. Mm-hmm. And so in medicine, and particularly when we look at medicine, we view in theory and principle as medicine being able to keep us fit, to be able to function, and to be able to thrive, and to really live the life and experience abundant living as our Savior has so deemed for us to enjoy. Mm-hmm. But one of the challenges that again, this COVID-19 has done, it has shown a giant spotlight on the health disparities between African Americans and whites. And really, this is an ongoing problem, and it's a problem that has existed prior to COVID-19. Mm-hmm. But it's just magnified and brought up once again much of what many have known and recognized and have documented. Cigna Health and Life Insurance Company did a study on health disparities, and one of the things that they highlighted was the fact that 48% of African American adults are obese. There's high rates of severe childhood obesity. 80% are more likely to be diagnosed with diabetes. 2.5 times more likely to begin treatment of end-stage renal disease. 1.5 times more likely to be hospitalized. 20% more likely are African Americans to have visual impairments. Men are 30% and women 60% more likely to have high blood pressure and less likely to keep their blood pressure under control. And men have twice the risk for first-time uh, stroke.
Hmm.
Uh, 1.8 times of our children are more likely to have uh, ever been told they've had asthma. 3.5 times as likely to die as infants due to complications related to low birth weight. 2 times higher, we have a 2 times higher infant mortality rate. Those are just some few things that as African Americans that challenge us and give view to the disparities between our counterparts.
Hmm.
And certainly as we look at COVID-19, the CDC back in July acknowledged specifically, and I quote, long-standing systematic health and social inequities have put many people from racial and ethnic minority groups at an increased risk of getting sick and dying from COVID. And the CDC goes on to say in this report dated July 24th of 2020, that is, there is increasing evidence that some racial and ethnic minority groups are being disproportionately affected by COVID-19.
Hmm.
Hearing those things just from the onset, as someone who is committed to the wellness of people, who sees their practice of medicine as a calling rather than a pursuit of vocation, one who has a passion for wholeness and wellness, just hearing that data from Cigna along with that issue through the CDC, how does that affect you and how does that make you feel?
It hurts.
Hmm.
It does. It hurts. It hears that. I mean, it hurts that I hear that brothers and sisters are dying at higher rates, not only from COVID-19, but from all these other disease processes that you mentioned. And I think that we've become somewhat desensitized to this. We have, come to understand, well, people of color, we suffer from these chronic illnesses, and we're likely to have a higher risk of dying from these chronic illnesses. But what we don't tell is the backstory. And
Yes.
the backstory is that there are, policies, patterns of thinking,
Hmm.
bias, structures in society that actually help create these disparities. And
Hmm.
we're not talking about a disease process that attacks people of color just because we're people of color. We're
Hmm.
talking about a disease process that affects us because what society has done to people of color. And I
Hmm.
think that as we think about all of these things, which are the offspring of racism, and
Hmm.
there are many,
Hmm.
as we dive into that, we can dissect how each of these things affect our wellness, how each of these things, limits our choices, how all of these things even affect our medical establishment,
Hmm.
and how we engage with people of color. And that's even people of color treating people of color. So
Hmm.
it's an intricate, deep process, but the bottom line, it hurts. It hurts to hear that.
Talk a little bit about that because you mentioned something that I had not considered, how African American physicians treat um, their African American or people of color
Mhm.
patients. Do they operate? Does some of the systematic uh, um, uh, or inaccurate views of the cultures, does that seep into a Black physician's um, way of treating one of their African American patients?
Studies have shown that physicians of color, may also be at risk for treating people with based on assumptions and bias.
Mm-hmm.
And though training in medical school and in residencies are getting better and better all the time in trying to
Hmm.
identify that and trying to correct that, health systems are trying to be more aggressive in identifying that and addressing it, particularly as we have more access to data and our outcomes.
Hmm.
But surely, people of color who are in medical establishment, unfortunately, we also succumb to some of those poor decision making.
And that's critical because it just reminds me, just hearing you speak, almost like a African American police officer being guilty perhaps of one of their white counterparts, and making assumptions, profiling their own, and
Yeah.
not being effective as they could be as police officers because of this being in that climate and being a part of that culture.
Mhm.
They've kind of adopted and taken on some of their viewpoints. Um,
And if I can add to that, and I
mhm,
think that when it happens, I think that by and large, physicians don't go in the patient encounter with the intent of
mhm,
trying to not be a good provider or not
mm,
provide great care. I think the intent is to be the best
mhm,
provider I can be or provide the best care. But
mhm,
some of our biases are, unconscious. And,
mhm,
most of us practice within settings where the institution or the environment has policies in place which really haven't been clearly dissected
mhm.
to show that it has inherent bias, racism, which can affect the care of patients.
In those environments, is it easy for a Black health professional or physician to speak up and as a part of a health system, as a provider in the health system, to if there are policies being made to kind of speak and kind of bring that culture perspective in a policy or a treatment approach to a certain group?
I think that, if we were to have this conversation perhaps 30, 35 years ago, I think it would have been a lot more difficult.
Hmm.
But now we better understand
Hmm.
how these various social determinants, these
Hmm.
things that
Hmm.
affect outcomes, which have nothing really to do with the pill that I prescribe or the stethoscope I put against your chest, but these
Hmm.
other things which affect outcomes for clients. I think that's been placed more so on the table for us to discuss.
Hmm. Hmm.
Culture has been placed more on the table for us to discuss
Hmm.
its effects on outcomes. So now we have data to
Hmm.
substantiate what our claims.
Hmm.
We've had concerns about how we improperly diagnose or how we don't adhere to treatment guidelines or how we don't always seek the least invasive intervention to be able to get the best outcome. Now we have data to back us up when we go
Hmm.
to our institutions and establishments hoping to change how we deliver care for better outcomes.
Yeah, in terms of one of the things that many people, whether what your skin color is, and no matter what ethnic group you belong to, is you're always encouraged as a patient to become as an informed patient to read up on whatever may be ailing you, whatever disease may have befalled you, to talk about that and to come as an educated um, a person or patient. And certainly, I think that those things help. But what we have seen is that one of the things that information that's being provided, especially during these times, during social media, again, even when it comes to COVID, that the whole that linkage between what's historically happened and how that may be playing out with this present pandemic. The CDC says that inequities and social determinants of health that put racial and ethnic minority groups at an increased risk of getting sick and dying from COVID. One of the things it lists is the fact that they acknowledge discrimination comes and plays a very important part in perhaps putting a person of color, an African American, at increased risk of COVID because they're discriminated. It talks about they also lift up access to hospitals
Yeah.
and how that plays a role to mention, along with the occupation of many of African Americans who are essential workers.
Hmm.
At their grocery stores, they're there on the front lines, and they are the ones that are helping things keep going. They're not getting paid a lot of money, and if they're not at work, they lose wages, they lose income, but they don't have the flexibility to work from home. They have to be out there, and so because they have to provide for their families, one of the things that the pandemic has done is put folks in a position where they have to do and risk a lot. And so when I think about the disparities, I think about the present pandemic and how what has been embedded and what has been acknowledged by many has been a long standing problem, or something that needs to be corrected. And so what we are seeing now, Dr. Moss, as we look at the Pfizer vaccine, as we look at the Moderna vaccine, there seems to be a hesitancy upon African Americans to get vaccinated. And what we've also discovered is that the hesitancy is understood by those that have been vaccinated, those who have developed the vaccination. And so here is an ad which was put out by Pfizer as they began their study, encouraging African Americans to participate.
For too long, Black community health concerns have been ignored, under-resourced, underappreciated, undervalued. COVID-19 has highlighted deep racial and ethnic disparities across the United States. But now, you can have a voice in what happens next. People from all backgrounds are needed in clinical research, especially our Black communities. Be represented. Go to Pfizer.com/clinical trials to learn more about our commitment to ensuring all communities are represented.
So here is a pharmaceutical company, understanding the need that whatever research that they do, that it's inclusive. And then to acknowledge that historically, persons of color have not had the same access to health care as their white counterparts.
Mm-hmm.
And so as an essential worker, as a frontline worker, tell me about your decision to or not to receive the Moderna vaccination or the Pfizer vaccination. Which one was made available to you?
So the health department had the Moderna vaccine available. And I got the vaccine on the 22nd of December.
Mm-hmm.
And, I did, give some significant thought into doing this. I as a psychiatrist, I'm continuing to see people in the office, and I see people who are very sick, not only necessarily just from the mental illness, but people who are coming in very sick from addiction, needing detox, often needing other types of medical treatment. Mm-hmm. And my team has been happy and courageous in providing. But it also allows for me to have exposure to a large number of people. Mm-hmm. Across a large swath of our society. So I take care of people who we may deem, based upon their exposure to other people, that they may be low risk, but also take care of people who've been homeless, who are indeed high risk individuals, being in contact with other folks, unprotected. But I wanted to take my fight in regards to the virus. I wanted to take it to the virus. I didn't want to wait to become infected by someone, whether at work or out in the community. I wanted to make sure that I could manage this in my own time and on my own terms. So getting the vaccine allows for me to be able to have, genetic material that's my body's been exposed to, so that now, when I get the real virus, if it were to come my way, if I were to contract that, my body already has an answer for it. My body already has a fight that's built up for it. So hopefully I'll have less complications from being infected. And if I have less complications, that means that hopefully my rebound time will be pretty quick. If I get infected, I do isolation, but I'm continuing to be healthy and be able to work in the way that I need to be able to work and take care of my family, to take care of my practice and my patients. Mm-hmm. I have underlying health conditions of, obesity. It may not look like it, but I am overweight. And I also have a significant hypertension that requires me to take a couple of medications to maintain. So that places me in a high risk category, for having complications from this virus. So I wanted to make sure that I protected myself such that, I don't become hopefully ill if I were to get the virus. And then the other part of this is that I don't want to be an additional, drain on the health system. By me getting this virus, it also reduces my risk of having to receive medical care if I get infected, and hopefully reduce dramatically the risk of me being hospitalized if I were to get the virus. So it was important that I take care of myself, but this is also a part in being able to take care of my patients and take care of my community.
Thank you for your transparency, because it's that realness is which is going to help other people say yes. I myself have not have not been offered that. Certainly I know who I could push the envelope with to make sure that that happens. As I see pastors as essential workers as well. I might ask you the question. This is a new class of drugs, or it's happened pretty quickly. And what I know as a layman, that the old vaccinations work by putting some of the disease in you, or a snippet of it, or something like that. So how does this class of drugs, or this approach to treating this virus, different from the traditional approach in vaccines?
Well, this is a 2-injection virus, and we're hoping that we can inject material within me that my body then is able to present in a very effective way to the rest of my immune system. This science and being able to develop this has been under works for more than a decade. It seems pretty quickly that we were able to get this vaccine, within a year's time. But the technology to be able to do this has been studied for quite some time. And it allowed for us to be able to bring a vaccine quickly. And what one company learned about how we managed this in creating this vaccine, other companies were giving the similar technology. So there's no reason to have any concern about how Moderna and Pfizer have come out with a vaccine. Johnson & Johnson is going to come out with a vaccine. And there are actually 3 other companies behind Johnson & Johnson that are also going to present their version of this vaccine with the hopes of being able to safely treat and inject people for protection for those who are asking for it.
And the challenge is, Dr. Mouse, really is it's trusting science, and it's trusting that again, that everyone who's involved in the research, everyone who is administering the vaccine, is adhering to and is invested in, once again, to that oath, do no harm. And so historically, as a people, we have been non-trusting of health professionals and science, and for some good reasons, and some myths or folklore in the community. But one of those things that has happened throughout our history, or an example or a reason for some of us to be apprehensive about participating in a trial or receiving a drug, is the Tuskegee experiment, in which that there were some. It began in 1932, and there were some 600 folks a part of the study, males there, and at least 399 of them had syphilis. Another 201 did not, and they didn't really treat them with the drug. They gave them aspirin and mineral oil. And they just and they really weren't trying to treat them. They were just trying to see how the disease progressed. And at least 100 of those folks developed blindness and went insane. At least 40 women or 40 spouses of those men contracted disease. At least 18 out of that group passed that on to an infant in the birth canal. And so this was something that went on for a while. The government instituted it. Researchers, again, though they were monitoring what was going on, 15 years into the study, it became known that penicillin would be one way to treat this. But those researchers, those that were monitoring those in experience, did not offer penicillin as a remedy. They still continue to allow those to suffer with this disease. And it is only in 1972 that it was broken and shared with a Associated Press reporter who came forth and brought it to light, and then there was something done to try to end it. But apologies were made, and even by President Obama at the time, because 10 years prior to that, or there was something done in Guatemala, the same type thing, where they were purposely infected with the illness or attenuator it is, to see if penicillin worked, and just to see, and they were guinea pigs. And so there's a legitimate concern that taking new drugs, that in some way this is the 2021 version of the Tuskegee project. What do you say to people who have that point? You alluded to the science behind it, but I noticed that one of the strategies that has been employed by the government is to have African American doctors administering the vaccine to African American health employees and African American healthcare workers, to try to put at ease. But what else can be said that can help us? Because one of the things about folks we do know is that some of us as African Americans just don't go to the doctor.
Yeah.
And one of the things older folks will say, well, I went to the doctor for one thing and they told me I had to do something else. I ain't going to the doctor no more, because every time I go to the doctor, it's something else. And so that's kind of culturally, I ain't going, I think I got a sore throat. He might tell me I got cancer. I'm not going. So what do you say? And how do you respond, once again, as a professional, kind to alleviate that and dispel some of that, and I think, because I think you got to value the concern, but at some point you got to weigh it out.
I think that the Tuskegee experiment was a great trauma.
Mm-hmm.
It was a great trauma to medicine. It was a great trauma to Black people, and is unconscionable in our vantage point now, looking back and wondering how in the world could that have ever happened, but it happened in the same way that, slave women were operated on experimentally for, obstetric and gynecological procedures, in the same way. So I acknowledge the hurt, I acknowledge the trauma, and I do understand why people have a great deal of mistrust. What I will say is that, just an example, in my early career as a resident, and following that, being able to participate in research as a sub-investigator, that there are so many checks and balances and layers of oversight that you wouldn't believe that take place in research now. As an investigator, I have to get peer reviewed by other colleagues to see if my question has merit. Then I have to get reviewed by an independent board, which the independent board is composed of oftentimes physicians, other types of scientists, but also community leaders are also part of that board. And they give oversight to assure that this question that I may have that I want answered by research is something that's valid and that's safe. And then the United States government has a part to play in doing oversight to make sure this question that I have, this research that I want to do, to make sure that it's safe. And then above that, the Food and Drug Administration gets involved. All of your data has to be reviewed by them. It's interesting, when we develop a medication, for therapeutic use, we have commercials that come out that talk about that, right? And then you hear all of this list of side effects, right, that come in that commercial. And the reason being is that every time that someone's involved in a clinical trial regarding medication, even if it's one person who had a particular side effect from a medication, that's going to be documented and that's going to be communicated to anyone who's prescribed the medication. There are so many layers of checks and balancing and quite frankly, policing that have offered, I think, a safer way for us to be able to do research. And interestingly, I learned about the Tuskegee's experiment and its details and all of the other atrocities, that happen in research,
Mm-hmm.
not necessarily in medical school,
Mm.
but in the certified training that we have to get in order to be credible to be able to perform research.
Wow.
So people are well informed. This is a past that we don't want to repeat for sure. And there are a number of layers of safety that are put in place so that we don't have those atrocities again. I would even go on further to say,
Mm-hmm.
when we think about this vaccine,
Mm-hmm.
and for this vaccine, they've had 30 and 40,000 people who've
Mm-hmm.
received this vaccine in clinical trials.
Mm-hmm.
When we think about typical medications that we prescribe and a number of people in those trials, those initial trials are usually 100, 200 people.
Mm.
So people are getting access to a vaccine that's been researched over a larger body of people to be able to get as much safety data as we can to make sure that we can put together the best available product to be able to provide safety and protection for people who don't want to have complications from this virus. So I think that what we're looking at as far as research that's been placed into this vaccine, I think that companies have gone over and beyond. And I'll go on to say, when we think about research, it's very important that we do get people of color to participate. When people of color participate, then we can better understand how specific medications may affect people of color. And they inform us as physicians about how we may prescribe medications. So it's very important that people also see that angle. That's important for us to be able to participate in research so that we can come up with the best treatments that also help people of color.
Two final questions, Dr. Moss. I want to hit back on something you expressed, and certainly thanks for that information, because we need to know that 30 to 40,000 folks have been in these studies as and normally would just be 100 folk or 200 folks. So that's really should be reassuring for those that perhaps still have some trepidation or some problem with taking the vaccination. But one of the things that you mentioned earlier, and I want to just kind of end on a note, is do you believe, as a African American physician, I mean, you are a diamond in the rough, and you're especially being psychiatry. Do you believe that there is a genuine lack of trust or credit, or do the Black physicians face a credibility problem from their own and from their from other patients, from potential patients from other races?
So let me make sure I understand the question. Do I believe that there's a credibility issue for physicians of color from patients who do and do not look like them?
Correct.
I do agree that that takes place. I think that it's gotten better. Early in my training and my practice, I experienced that a great deal more. Having physicians, having patients, would defer to Caucasian physicians, and people of color who come to me actually, deferring actually to who's the other provider,
Wow.
that type of thing. But I think that's actually gotten better.
Okay.
And now, and there may be some others who may be able to who've had this experience too. But I'm in a community here in Hamilton, which is not downtown Cincinnati.
No, sir. No, sir. No,
And
sir.
though there is some diversity here in Hamilton, we have a large Caucasian, a large Appalachian population, where I feel that myself and my team have been well received, and in many respects, I've been sought after, by those same clients. So I think that that's getting better. I think that in general, it's difficult to engage like we would like people of color to come in for care. to come in to receive the treatment they need, even for preventive care, to take care of the things they need to take care of so that they don't have poor outcomes. That's a challenge across the board. And physicians like myself and others are looking and learning, trying to find ways that we can better engage in DHRS and provide some education so folks can get the care that they need.
Awesome, awesome. So if I am a person of color and I feel as though that I am not getting the best of care, how do I make the decision as whether to stay with my physician or to challenge them to make sure that they have not bought into ideologies or viewpoints of me that prevent them from giving me or affording me the same opportunities? And I think about the Reservin, or I may be mispronouncing, the treatment that was offered to the president and to Governor Chris Christie, and even Rudy Giuliani, who has been documented, have gotten this cocktails for treatment. And it's a prime example of classism to me, where if you afford these drugs, that's the best of treatment. But the guy on the street may have the same numbers, if you will, from the lab, or the same respiratory rate and the same oxygen level, does not have that access. And so how do I deal with that? I feel like I'm not having access to what other people have access to.
Well, I think that education is the key, and that is to learn about your particular condition or disease process and find as much information as you can about what's available to treat that. And you should feel confident that you can take that information. Some of it may be true and some of it may be false, right? But take that information to your provider and request a dialogue about how did you diagnose this condition and what my options might be. And if that provider is worth their salt, he and she would be willing to sit down with you and say, this is how we came up with this diagnosis, or this is why we think that you have this diagnosis, and this is why we think this treatment would be a good fit for you, or this treatment would maybe a better fit for you. But having that dialogue, if you are with a provider and that provider is not willing to have that dialogue with you, and their final answer is simply because I know that this is the best treatment for you, that's the best answer they can give you, then perhaps, you may want to consider other treatment options. If their only answer is, I'm a doctor and I know, and you're a patient and you don't. I've had some of the most interesting and, I think rewarding engagements with clients who come in with what they think their diagnosis is, but also what their treatment options are. And then we're able to negotiate what a plan together will look like that they feel comfortable with, that also feels will help them get to their goals. So being able to have that information, having that education about your process, or at least questions, and bringing that to your provider and challenging them to see if they'll be willing to sit down and have a conversation about those options.
So if your health provider, your physician, their response is, because I said so, perhaps maybe your response should be, deuces, see you later.
We live in a medical culture now where we as providers are competing to take care of you. We're competing to take care of you. And so, we want to be the most informed. We want to be the most engaging. We want to be the most woke when it comes to your culture, your environment, and how we can customize an intervention for you. So use that to your advantage.
Well, this has been all inspiring and quite helpful. I know to myself, and I'm sure to those who have been coming in and out, and those that will view this at a later date. Thank you, those of you who have stayed with us, and those of you who've come in and out. This once again is our first episode, specifically dealing with the topic of the real on racism. We hope that you will join us throughout the month as we will dive in a little more and tackling this elephant that's in the room, racism. But until then, on behalf of myself and Dr. Moss, we want to encourage you to feel better, to become better, and to live better. Good night, everyone.